Okay, thanks very much for joining us today. We're going to be focusing on how behavioural science and implementation science can help cancer health systems to regain lost ground post-pandemic and strengthen provision to address cancer burden in the future. My name's Kate Hamilton-West. I'm Head of Social and Behavioural Research at Cancer Research UK. I'm also an Honorary Professor of Health Psychology at the University of Kent, affiliated with the Centre for Health Services Studies, and a steering group member for Cancer Prevention Europe. And I'll be co-presenting the session today with Kriti Chauhan, who is Associate Engagement Director at Busara Centre for Behavioural Economics in India. Also with Ariadna Feliu, who is Visiting Scientist at the Environmental and Lifestyle Epidemiology branch of the International Agency for Research on Cancer, and with Bill Klein, who is Associate Director of the National Cancer Institute's Behavioural Research Programme in the US. So we hope to provide a flavour of the way that we're working in behavioural and implementation science across each of these regions. So this is the aim of the session today. So we aim to illustrate the role of behavioural science and implementation science in addressing challenges facing health systems around the globe. And these include tackling cancer risk factors, including newer and less studied risk factors, reducing reliance on misinformation, increasing public participation in screening and HPV vaccination programs, empowering people to seek help earlier, enabling clinicians and community health workers to adopt best practice, and advancing evidence-based innovations to scale. So in terms of the scope of this session, we aim to consider how behavioural science models and frameworks may be used to identify and address barriers to cancer-relevant behaviour change, also how implementation science frameworks and strategies may be used to identify and address barriers to equitable and widespread adoption of best practice innovations. And we also aim to consider opportunities to advance the integration of behavioural and implementation science into cancer prevention and control through working globally across disciplines and sectors. And the presentations today are really set within the context of the impacts of the coronavirus pandemic, which, as we know, have undermined many cancer-relevant behaviours and also starkly highlighted the effects of economic and health inequities present in access to healthcare and cancer treatment. And you can see on the right-hand side here some figures from the World Health Organization Pulse survey on continuity of essential health services during the pandemic, which illustrates significant disruption across all regions, but the impact, of course, was not felt equally across each of these regions, and there's disproportionately greater impact in low and low middle income nations compared to higher income regions. So the format for the session today will include 4 relatively short presentations. We're aiming to keep these fairly brief so that we have some time for discussion at the end. And we also wanted to share with you today some tools and resources from our own organisations that are valuable for researchers working in this field. So the first is Cancer Research UK's Cancer Awareness Measure, or CAM+. Some people may be aware of this survey, which is conducted regularly to understand UK public attitudes, awareness and behaviours across early diagnosis, screening and prevention. Also, the National Cancer Institute's Health Information National Trend Survey of US public knowledge, attitudes and use of cancer and health-related information. From Busara, we're highlighting the Little Jab book, which provides 18 behavioural science strategies for increasing vaccination uptake, as well as tools for healthcare professionals to increase HPV vaccination uptake. And also the National Cancer Institute's searchable database of evidence-based cancer control programmes, where researchers and interventionists can read about and download evidence-based intervention material. So I have embedded links within the slides, but unfortunately you won't be able to access those from the slides. So if there are any links here that you would find helpful, then do get in touch afterwards and I can send those through to you. Okay, so I'm going to pass over to our first presenter, Kriti Chauhan.
Thank you, Kate. I would just like to start with a quick introduction to what my organization, Busara, does. We are trying to advance and apply behavioral science in the Global South with the aim of poverty alleviation, really. One of the problems that we realized is that if you see the world map scaled to population, you can see how big Asia and Africa are. But when we scale the world map to published research, you can see Africa almost vanishes. So what we at Busara are trying to do is really bridge the gap between published research and the real world. And also we realized, having worked in this space for the last decade or so, that you can't just really pick studies or evidence from the global North countries and apply it to the global South countries and expect them to work. So that's one of the aims that we have at Busara, which is to bridge this gap. But the project that I want to particularly speak about today is the project we did around driving the uptake of the HPV vaccine in Kenya using behavioral science. Just a bit of a context. I don't think these numbers are will be very surprising. It's common knowledge that about 16 million women are at the risk of developing cervical cancer, out of which I think about 5,000, more than 5,000 are diagnosed with cervical cancer every year in Kenya, and about 3,000 die from cervical cancer. It's the second most frequent cancer among women, and about all of the cases of cervical cancer caused by HPV in the country. However, only 3.5% of women aged between 25 to 64 are actually screened for cervical cancer in Kenya, which was the context at which this project was really set. So the Kenyan government in 2019 scheduled the vaccination rollout for the HPV vaccine, which was to be delivered free of charge to all girls who are 10-year-olds through public, private, and NGO-based hospitals and health facilities. Then Busara, in collaboration with Burness Women for Cancer, and with a lot of support from American Cancer Society, undertook this behavioral research project, where we tried to create evidence-based but also low-cost and really contextually relevant solutions, behavioral communication solutions really, to target parents to improve their intentions to get their daughters vaccinated. It was, like I said, it was a collaborative effort among a lot of partners, the government, there were CSO partners, we had American Cancer Society, but also UNICEF inputting in our strategy, in our solutions throughout the way, as well as Busara was the research partner and Burness was the comms partner. Our approach was really, it was a three-phased approach. We started with something called formative research, where we not just looked at the structural and environmental factors, but really focused on the behavioral and cognitive factors that would influence the uptake of the vaccine among parents using something called as the MAO framework, which is the Motivation, Ability, Opportunity framework, also called the COMBI model in behavioral science very often. We then moved on to co-design communication interventions based on the findings of the formative research. We prototyped them with a lot of stakeholders, including parents of adolescent girls. So this was really a user-centered approach that we used, where the end beneficiaries were a part of the research process, were a part of the co-creation process. And we finally tested those solutions out to figure the best solution that could be scaled up. Just a few key insights that I wanted to quickly touch on since we don't have a lot of time, but happy to speak more about them later. We identified and divided the barriers as well as enablers across motivation, ability, and opportunity. And we found the biggest factor here that was hindering parents from getting the HPV vaccine for their daughters was that they had lack of perceived sufficient information. They didn't feel like they had enough information about the vaccine to get their daughters the vaccine. Then, of course, there were other factors like social stigma around the vaccine, because HPV is an STD, so there was a lot of social stigma around that. Parents did not know where or when to get the vaccine. There was a lot of gap in the practical knowledge that parents had. There was literally none. They did not know where to get the vaccine. They did not know whether there was a cost attached to it. They assumed there would be. Then distance to the health facilities was another factor. And one of the biggest factors was also misinformation. They all thought that, or at least a lot of parents thought that the vaccine would lead to infertility or side effects like that, were some risks of the vaccine. However, we also found some levers or enablers that we thought would, if leveraged correctly, would encourage uptake of the vaccine. One of the biggest ones was the sense of responsibility that the parents have for their children. And they really did understand the importance of vaccinations because they had good past experiences. Polio vaccine almost every time came up. The campaign for the polio vaccine was a huge success in Kenya, which came up every now and then. Parents did understand the importance of preventative healthcare measures. They also had a big fear of consequences of cancer. They understood what the consequences of cancer were because cancer was just so common. What we then did was we took all of these barriers and enablers and conducted like a co-design workshop with a lot of stakeholders, which also included parents, to create an SBC communications package, which had an element of endorsement where the HPV vaccine was to be endorsed by a trusted messenger or a trusted source of information, a testimonial where cancer survivors or people who had gotten the HPV vaccine would leverage their personal stories to encourage other parents like them to get their daughters the vaccine, and some text nudges, which were like regular nudges to remind parents to get their daughters, whoever is eligible to get their daughters the vaccine. However, we did not test the endorsement or the testimonial or the text nudges. What we did test were some key aspects of these interventions. We wanted to understand the best way of delivering a message and the channel of delivering a message. So we tested two key aspects, the framing of the message and the messenger. We created all of the interventions or all of the communication solutions. We created like multiple versions of it. One was where we framed all messages in a very negative way, which we called fear was the theme, where I'll show you what the message was. The other framing was gains or aspirations, which was much more positive and leveraged the sense of responsibility that the parents had for their children, and social norms, which was just to normalize this behavior of getting their daughters the HPV vaccine. We also tested whether male doctors or female doctors would work better to deliver this message. These were the posters and the text message campaign that we tested for different framings. So if you see fear, it was a really strong negative message that, cervical cancer kills so many women and your daughter could be one of them. Whereas the aspirations poster was much more positive and the social norms poster was just trying to normalize the behavior. Then the messenger was, we just tested whether the message would work better coming from a female doctor or a male doctor. What we found was, social norms didn't do anything really. It was as good as the control, which was some communications posters that were already on the ground by the government. What did do well was the aspirations poster, the aspirations framing in really improving the sufficiency of information and trusting the information. Parents trusted the information when they saw it from that framing. Fear just backfired, and I can talk more about that later. For doctor recommendation, we found, doesn't matter, irrespective of the gender, as long as the endorsement is coming from a health worker, from a doctor, it works. Just very quickly, a few key learnings we had was parents do have the sense of responsibility for their children, so leveraging the sentiment in vaccination promotion initiatives could really improve the intentions of parents to get their daughters the vaccine. Using visual communications of a doctor's support for the HPV vaccine really worked well, especially in low resource settings where doctors aren't very available. Using their visual communication from them can really help. The one big learning we also had was the importance of understanding the audience and their context. Usually text messages have worked in the past, but they did not work in our context owing to busy schedules that people in low resource settings in Kenya had. They did not really pay attention to any SMS and did not have the time to engage with an SMS campaign. Also, framing of the vaccine as a cancer-preventing vaccine did much better than just framing it as an HPV vaccine. Finally, in the last minute, we converted all of these insights into an action guide. We have created an action guide for the civil society organizations and ministries to really support them when they engage with community health workers, when they engage with healthcare facilities, to really help them understand how best to frame messages, how best to deliver messages, what job aids could be used for community health workers to deliver the message in the right way that could really move the needle here. I think I'll just stop here. Thank you.
Well, I'm really honored to be here with all of you. Thank you for the ones that stay till the end of today to be here. I'm very happy to be able to share with you how we applied behavioral science to understand how cancer prevention recommendations are perceived among EU citizens. So, health literacy has been defined by the WHO as the cognitive and social skills that help individuals have the motivation and ability to use information, gather it, and also understand it to promote and maintain good health. So understanding health information is an integral component of health literacy. Interventions that can improve health literacy can lead to changes in health behavior. As although we know that knowledge is often not enough to change behavior, for an individual to perform a change in their behavior, they need to understand why they need to do it. So providing access to high-quality health information is crucial to inform decision-making on prevention, cancer prevention at all levels. So the World Code Against Cancer framework is a multi-stakeholder initiative that was launched by IARC in 2022 to promote cancer prevention globally. The World Code Against Cancer serves as an umbrella to develop and update regional codes against cancer, and it aims at transferring the latest evidence from etiological cancer research and preventive interventions into actionable information on primary and secondary prevention of cancer to the general public, health professionals, and cancer advocates, and also policymakers. We know that behavior is very influenced by the environment in which people live, and therefore population-level intervention approaches targeting different audiences have proven to be more effective, more equitable, and long-term sustainable strategies to modify exposures to prevent cancer. So the World Code Against Cancer framework uses the European Code Against Cancer as a model. The European Code is a long-lasting initiative of the European Commission that is a cancer prevention education tool and describes 12 ways to reduce individuals' cancer risk. It is a set of recommendations that tell individuals what they can do to avoid or reduce their exposure to established causes of cancer and to participate into vaccination and screening programs according to national guidelines. So the Europe's Beating Cancer Plan that was launched in 2021 announced the update of the European Code to contribute to improve citizens' health literacy on cancer risk and its determinants and what preventive measures there were. And they set the goal to make at least 80% of the population aware of these recommendations. there has not been a systematic monitoring of the awareness or the impact of the code over the years, but results from a study conducted by IARC together with the Association of European Cancer Leagues showed that although the level of awareness of the population was low, it ranged between 2 and 21%, 60% of the population were willing to make behavioral changes for cancer prevention after reading the recommendations. So the Commission, to update the 5th edition of the code, offered us the opportunity to conduct some formative research to be able to describe the needs of our audience, understand which factors influence the changes of behavior, and also to understand what was the best way to reach this audience. So for this reason, we use the COMBI model. As my colleague already mentioned, this is a behavioral change framework that identifies which components of behavior need to be changed for a behavioral change intervention to be successful. This model states that there are 3 components that need to be there for any behavioral change to occur. And these are capability, opportunity, and motivation. It states that for any individual to conduct a behavior, in this case, adopt a cancer prevention recommendation, they need to feel that they are psychologically and physically able to do it, that they have the social and physical opportunity for the behavior to happen, and they want to do this behavior more than any competing behavior. So this model recognizes that many factors that influence behavior, but that by changing one of them, we can achieve behavioral change. I just want to introduce you the behavioral change wheel as well, because it's a method for characterizing and designing behavioral change interventions, and it has helped intervention designers to select between different types of interventions and policies that can be used to ensure that what we have found out using the COMBI model can be assessed, changed, and made better. So as for our project, our aim was to explore individuals' perceived capability, opportunity, and motivation to adopt cancer prevention actions recommended by the European Code Against Cancer, and to identify the barriers and facilitators citizens found to adopt the recommendations in the EU. For this purpose, we designed a qualitative research study with exploratory methodology in which we conducted in-depth semi-structured interviews among adults with no previous diagnosis of cancer. We included in our study 9 EU member states, and we tried to get at least 18 different profiles to ensure that participants were from all age groups, different sexes, and also we had different educational levels included, because this is what, according to the literature, was relevant to our research question. So, as preliminary results, the predominant factors found for capability were personal health literacy. And this includes not only health knowledge, but also health-related skills. And this was about information management, knowing where to find trustful information, but also own self-management, knowing what services were in the community and how to access them. Also, psychological resources were very important. Our participants stated that mental health was really important and having support was key. As for the opportunity, cultural and social influence were key factors. Also, the accessibility, availability, and the quality of the services that the health system provided. Several economic factors were also found very relevant, like affordability of products, for example. Also, time availability, and the regulations that were in place in the country and the policy context. And finally, as for motivation, what triggered their willingness to change their behavior was to have better health, better quality of life, and also to ensure personal well-being, but more importantly, loved ones' well-being, and the fear of cancer. And all of this is what made them want to change this behavior. So understanding how the European Code recommendations are perceived by EU citizens and the barriers and facilitators they encounter to take action is key to promote the adoption of these recommendations. to improve supportive societal and contextual structures to overcome these barriers, and to advocate for the implementation of policies that enable the adoption of these recommendations in the EU. I don't want to finish my presentation without acknowledging all the other colleagues that work in this project. Thank you for your attention. You have my contact details on the slide and also access to our website and the study protocol of the project. Thank you.
Thank you, Ariadna. Okay, so I'd like to share with you some information about an implementation research programme that we have developed at Cancer Research UK called Test Evidence Transition. And just to provide some context to cancer in the UK, we know from analysis by our cancer intelligence team that almost 1 in 2 people in the UK will be diagnosed with cancer in their lifetime, that cancer is the UK's biggest killer, that there are also very stark inequalities in who gets and dies from cancer, and analysis of performance measures across the pathway show that cancer waiting times are currently among the worst on record for all UK nations. This image is taken from our Cancer Research UK strategy, which highlights that gaps exist all the way along the pathway, from adoption through to implementation and impact. And the Test Evidence Transition Programme was designed specifically to address the implementation gap by working with health systems to make sure that best practice is rolled out consistently, effectively and equitably across health systems to benefit everyone. In line with this objective, there are 3 main aims to the programme. So the first is to implement proven service innovations to support the delivery of optimal cancer pathways at a local level. So these are service innovations where there's an existing evidence base, but they're not being implemented widely. In doing so, we aim to evidence the process as well as the outcomes and the impact of implementation at a local level, focusing on metrics that will drive adoption and spread. And we also aim to work with strategic partners to enable the effective and equitable transition of identified best practice across health systems. So I'd like to reflect on how the programme design has been informed by behavioural science and implementation science frameworks. So starting with the COM-B model that we've heard about already in this session, we had to think about how do we work with health systems teams to be able to implement service innovations and gather the kind of evidence that we need to inform widespread adoption. And this is quite a considerable undertaking for health systems teams who are very busy with service delivery. So we wanted to ensure that the teams that we work with in this programme have the capability and motivation to engage in this kind of work, and also that they have the opportunity to do so. And an important component of opportunity is having buy-in from their local level stakeholders. And that buy-in is important not only for enabling them to work with us during the duration of their projects, but it's also important for gaining buy-in to continue implementing these innovations beyond the end of the funded project, because we don't want them to just disappear at that point. Then thinking about the funding and support that we provide through this programme, we recognise that we need to provide a wide range of multidisciplinary expertise in order to support the aims and objectives of the programme. So this includes multidisciplinary expertise in areas such as patient involvement and engagement, qualitative methods, quantitative methods, health economics, behavioural science, implementation science. So we've also funded a team of academic partners to work really closely with these health systems teams and with our teams at Cancer Research UK to be able to design these projects in ways that are well aligned with the programme aims and objectives, and to be able to then conduct the right kinds of analysis of the evidence that arises from these projects. You'll see on the right-hand side that we're also enhancing opportunity for health systems teams to engage in this work by providing funding to those teams. We're also funding the academic partners to work with them, and we provide access to our stakeholder relationships as well. And in the centre is our active commissioner model. And what we mean by this is that we don't want to just provide funding and say, okay, you go away and do this now. We want to work really closely with these teams to enable them to navigate the kinds of challenges that people often encounter when they take forward innovation projects. And doing this means that we're also able to then gather evidence to understand what kinds of challenges do they encounter, what kinds of solutions might there be to those challenges, which helps to inform widespread adoption as well. And then finally, thinking about evidence and outputs, we didn't want to just produce academic outputs such as papers and conference presentations, although the projects will produce these kinds of outputs. But we also wanted to really think about how do we harness the learnings from these projects in ways that would enable others to implement these innovations elsewhere. So in order to build capability to do so, we're developing protocols, how-to guides and training plans. We're also developing case studies and patient experience, which is really important for building motivation. Sorry, should I speak louder? It is important for building motivation to engage in this kind of work. And we're working with these teams to develop business cases and financial analysis as well, so that they can then convince their key decision makers to access the resources that they would need to implement these elsewhere. So we were not only informed by the COM-B model, but by other implementation science frameworks as well. So for example, the RE-AIM framework that you can see in the center of the diagram here. And this considers not only the effectiveness of interventions, but also reach, adoption, implementation, and maintenance. So by this, what we mean is that we need to understand when we implement these innovations, who actually participates in them? Are there people we're not reaching, and why? And this is important for making sure that we're not widening inequalities. And we're gathering evidence to understand how we can continue to provide these beyond the end of the funded period and to scale them up. We also sought to describe the intervention components and strategies in line with the PRISM model, to consider overarching issues such as cost and adaptations, also to consider the fit with internal contexts such as patient characteristics and external contexts such as relevant policies and guidelines. In addition, we drew on the expert recommendations for implementing change, which we found really helpful for providing a very clear list of implementation strategies so that we could consider which strategies would be relevant to the programme, and we can also use the definitions within this compilation to be able to describe the strategies that we're using. And we used the World Health Organization guidance on developing a scale-up strategy, which I'd also really recommend to anyone conducting this type of work. It provides some really helpful guidance for thinking about scale-up right at the beginning of an innovation project. So this is where we are now. We have launched 3 projects so far in Scotland and Wales that you can see described here, and these are focusing on breast and prostate cancer. And then in April this year, we have launched 5 further projects. These are currently in the co-design phase, so they're not yet being implemented, and they will focus on bowel cancer. And we're aiming across these projects to have a spread across the UK nations, to also include areas of deprivation, to think about differences between rural and urban environments, for example. These are the partners and stakeholders involved in the programme, and that we couldn't take this programme forward without, so a big thank you to all of these partners and stakeholders. And there's a couple of publications here. The first one describes the development of the programme in more detail than I can do today. The second one describes the design and methodology of the two phase 1 projects in Scotland, and there will be a similar paper coming out soon for the project in Wales. And some discussion questions that I'd like to come back to later on when we reach that point, is to reflect on how we can embed implementation science in health systems and how we can balance academic rigour with real-world application. Thank you.
Okay, welcome everyone. Thanks for being here this afternoon. I'm going to give a different kind of talk than what you've heard, and then hopefully we'll have some time at the end to take your questions, including some of the discussion questions that you've seen so far, and maybe have some discussion. So you can see my title here. I changed it to sort of reflect on the fact that we've been plodding along doing research on behavioral science and cancer for years now, but suddenly this thing called a pandemic came along, and that really kind of flipped things over and made us think about things a little differently, and I'll talk about why. No conflicts to disclose. And just to tell you where I'm coming from, I'm from the National Cancer Institute, which is part of the National Institutes of Health within the United States. We're part of the executive branch of the US government, which presents some interesting challenges from time to time, but that's a different talk, maybe a hallway conversation. But it's important that we are working within the context of the government, and so we are trying very hard to take the research that we fund and the research that we do and have an impact on the public health of the United States. And I work within the Division of Cancer Control and Population Sciences, which is conveniently circled here on the org chart. Our program does two things. Primarily, we provide grants to investigators around the country and also around the world. And we have about 200 grants in our portfolio valued at about $300 million. So it's a significant chunk of money. And it's the biggest investment in behavioral science at the National Institutes of Health. And so we really can do a lot in the cancer space with regard to behavioral science. And here are some of our priorities, and they're probably not surprising to you. Obviously, tobacco cessation up at the top, alcohol, cannabis, and so on. And I'll mention at the bottom there, we clearly care about health equity and look at that across the entire spectrum. And cancer survivorship, which is now something to take very seriously. We have many more people being diagnosed with cancer and then going on and having productive lives, having families, having careers. So cancer survivorship means something different now than it did, say, 40 or 50 years ago, and that has an impact on how we think about behavior. I just want to point your attention to a paper that Kate thankfully cited, and it's a paper that we spent a fair amount of time working on, reflecting on what some of the current issues are that we need to address when doing behavioral science and cancer research. And you can see the list here. Number one is the effects of the COVID-19 pandemic, of course, and I'm going to say a little bit more about that. Obviously, the glut of misinformation and disinformation and just the changing information environment. We now know, for example, that teenagers and young adults are getting a fair amount of their health information, dare I say all of their health information, from TikTok. Well, that's a little scary because most of the information on TikTok is not being conveyed by scientists and government officials and so forth. Most of us are too old to know how to get on TikTok in the first place, so you can imagine that there's a big disconnect there. And then also methodological and technological innovation. We can do a lot more than we could before. The unique needs of different populations, such as people who are in sexual and gender minorities, Native Americans in the United States. These populations have gotten less attention and deserve more attention. And also, as I've said, the increasing number of cancer survivors, and also just the length of survivorship. This is a very busy slide, but really the take-home point here is that if you take a look at what's happened since 2020, since the advent of the pandemic, you see some interesting patterns. We looked at the literature in around 2021, 2022 to see what was happening and found that many articles, dozens and dozens of articles, were showing changes in behavior that potentially could be related to cancer risk. For example, it seemed as if physical activity levels were going down, sedentary behavior coming up. And then more recently, a paper came out showing actually the opposite for some behaviors. For example, the green line at the top here is heavy alcohol consumption. And it appears that that went down over the last couple of years. So we may have this interesting pattern where overall consumption has gone up across the population, but heavy consumption maybe has come down. We have to get our heads around that. As a result of that, a group of us wrote a paper in JAMA Oncology that really highlighted the need to understand what these behavioral effects might look like, say 20 years down the road. There's a lot of talk about how the pandemic got in the way of cancer screening and vaccination and other healthcare behaviors, and we'd like to think that those behaviors are now coming back, now that people can return to the healthcare setting. And of course, there's still progress to be made there. But those are behaviors that don't happen on a daily basis. They happen on, say, a 6-month or a yearly basis. When you look at physical activity, diet, etc., these are things that are happening at every moment, right? And if we see substantial changes in those behaviors over some extended period of time, we're going to see a change in cancer morbidity and mortality 20, 30 years from now. And so we think it's really important to pay attention to these behaviors and try the kinds of things you've heard about in the presentation so far, as well as many that we're funding. So I just want to point to 3 examples of behaviors that were potentially affected during the pandemic and about which we're trying to do important work in the policy and implementation space. We don't do policy, we're a research organization, but we do the work that potentially can inform policy at other levels of government. And I'll start by pointing out that alcohol is sort of the new kid on the block. It's not talked about very much, at least with respect to tobacco and some other behaviors, but it is one of the leading causes of cancer, behavioral and preventable risk factors for cancer. And you can see on the right side of the slide, in a national survey we did, we asked people whether they were aware of the link between alcohol and cancer. And some people thought that alcohol increased risk, some people thought it decreased risk, but really the real story in this graph is what's happening on the right side. About half of the population said, I don't have a clue, I don't know. And that's important. We need to address that. And if you attended either of the 2 really terrific sessions the last 2 days on alcohol and cancer, you know this is happening all over the world, not just in the US. So we've been doing some interesting work in this space. We've started doing some warning label research to understand what kinds of warning labels on beverages, for example, might have an impact in changing this low level of awareness. And I had a poster or a flash talk, a rapid talk on this earlier today that's highlighted up in the right there, and it's also online with all of the flash talks for the conference. So you can take a look at that, and happy to answer questions about it. But we're looking at lots of different factors, like what about message certainty? Should you say alcohol causes cancer or that it's linked to cancer or may cause cancer? What about the risk relationship? What about the warning source? Should it be the government or the Surgeon General, who is the leading medical professional in the US and has the imprimatur of medical expertise in the US? A second example I want to point to is that the tobacco industry was taken to court some years ago for lying to the public about the addictiveness of their product, and were forced to develop corrective statements, as they're called, at point of sale. So when you go into a store, these statements have to be right there where you buy the product. You can see a picture of that in the lower right here. And our staff were involved in developing some of the early versions of these corrective statements and testing them to see what might be most impactful, most believable, et cetera. And we're really pleased with the statements that ended up. They're a little watered down. That's what happens when you confront the tobacco industry. They're not quite what we started with, but I think they're important statements that, again, smokers are going to see right there in front of them when they walk into a store that has tobacco products. And then a third example, we have a resource that we've built up called Classification of Laws Associated with School Students, and the acronym is CLASS. I don't come up with these. I have very talented people I work with who are great at acronyms. And what this resource does is it collects together policies that are related to obesity outcomes, like the kinds of foods that are permitted to be in vending machines in schools and physical activity guidelines. And these data can be downloaded and then linked to obesity outcomes in some very interesting ways that in turn can affect policy. So we think this is an important resource. So I just want to highlight those 3. They're 3 examples of the kinds of work we do. And if you want to learn more about our program and what we do, here's our website. We have a newsletter that you can subscribe to. So take a look at that. And if you don't have time to write these down or take a picture, just go to Google and type in BRP and NCI, and you'll get right to our site. Here's my contact information. And I want to encourage you to visit our booth, the NCI booth, number 7 and number 8, where we have a lot more information about our funding opportunities and our priorities. But that's it for me. Now what I want to do, besides say thank you, is turn to discussion questions. So you've now heard 4 of us speak. We've had a chance to talk with each other about our common interests, and we wanted to create some space in this session to get into some discussion about some of the common issues. And I've really enjoyed hearing the 3 presentations that preceded me. We're all doing different work, but we're all kind of, hovering around the same basic questions and basic problems. And this is an opportunity to talk about that. So I think we're all going to come up stage, right? Oh. Thank you. And so these are some discussion questions we're going to try to tackle with your help. So I've been asked to kick us off. And I'm going to start with a question that Kate actually posed, but that I think is a really interesting one and a difficult one. And it's not just for us to answer, it's for all of us to think about. And that is, how do we balance the rigor of behavioral research? We were all trained to do, the kinds of work that's high in internal validity, hopefully high in external validity too, but really high in internal validity. But how do we do that in the context of the real world, where implementation turns out to be so complicated? And I thought we heard some really wonderful examples in the talks of doing really high-level, high-impact work in a way that still maintains internal and external validity. But it's a challenge. It's not easy to do. So I invite any of the speakers to tackle that. Does that mic work?
I can take that one. Thanks, Bill. Yeah, so this is a question that I posed, and also interested to hear others' views on this as well, because I think that in behavioral science and in implementation research, often we're sitting kind of between 2 worlds. So we have the world of academia with academic rigor around how we define the concepts that we're looking to measure and that we're looking to influence, the types of models and frameworks that we use, and lots of kind of research around when and how we use these. But actually, when we start to use them in real life, things become a little bit more complicated and a little bit messier. So how do we navigate those 2 worlds? And I think it's really interesting when you're working in that space to think about how can we use this as a way to guide our thinking and draw on these sort of models and frameworks really flexibly, but also not to be too pedantic, I guess, about saying, well, we have to do it in exactly this way because this is the way that it's described in this theory. If we can see that it's actually not working like that in practice, or it's not going to be relevant to the context or the population that we're working with. But also, if we do find that it's not working in the way that was anticipated, can we feed that back to inform the academic thinking around these models and theories and frameworks, and to be able to refine those as well?
Yeah, that reminds me that my implementation science colleagues, they like to say, don't let the perfect be the enemy of the good, right? Which I think is really an apt saying, and it captures this idea that you have to do something. You can't just be caught up in trying to do things perfectly.
Yeah, I would like to add to that because in our experience on trying to implement frameworks of implementation science in educational, health education, I would say, we've always have encountered some challenges. First, because most of the literature is implementation research is set for other types of intervention, like vaccines or treatments or something more clinical. So when we get to health education, sometimes it's difficult to how to use these frameworks and apply it. I don't know if anyone in the audience has also find these difficulties. So we plan to try to start using these frameworks for health education, and we hope we can have also an exchange with colleagues here or in the future to try to also build this particular set of knowledge, hub in implementation research, but for health education and health information tools.
Thank you. I think just adding on to what Adriana said, one of the things that we try to do is, like I mentioned, not a lot of research is based on the countries that we work on, that we work in, whether it's these frameworks or whether it's evidence. It's not really based in the countries, in the global south countries where we mostly work. So the one thing that we really try, which we hope is a step to bridge this gap, is to take all of the evidence, the academic evidence, all these frameworks with a bit of a pinch of salt, and first contextualize them for the local context or the audience that we want to work with or we want to work for, and proceed from there. That's the first step that we want to take, is just focus a lot on contextualization of whether it's an intervention that might have worked, that there is a lot of academic evidence on, or whether it's a framework. So what we try to do really is contextualization before moving ahead.
Terrific. Let me point out there's a microphone in the middle of the room. We encourage everyone to participate. And do you mind using the microphone just so everyone can hear you?
I didn't do what you said, but as you could notice, I hear absolutely nothing. So I deduce that you probably suggest that we go to the...
Just so everyone else can hear you, yes.
Because it is a feature of learned people that they don't care much whether we hear them, as long as they can put in the CV that they spoke on that and that topic.
Yes, thank
Go
you
right
so
ahead.
much, our panel of speakers. I'm called Fatia Chiange. I come from Uganda, working for a social justice organization. It's a civil society organization. Thank you for the presentations. Just to make an attempt and give an example of how we are trying to close that gap, is my organization is an advocacy organization. It's litigation, and evidence is very, very critical. So as much as we produce evidence internally within the organization, we've adopted a culture of looking at what is the evidence on the issues we work on that is coming through the universities. So for instance, we've had to collaborate with the School of Public Health in Uganda to take up the research that they have done and bring it into the policy, the policy spaces, and bring it into the spaces of legislators. Why? Because it's a public institution. The legislators and policymakers can easily take that research to be research that they can accept and utilize. So I think one of my observations is that research these days, especially academic research, is heavily driven by grants. So the grant will come, the research will be done, perhaps done in the communities. Maybe only one dissemination meeting will be funded under that. And once that dissemination is done with 30 people, that is it. Now, I think we as civil society, especially us who have seen the relevance of research evidence, it's up to us. We have taken initiative to go to the universities and say, this research is very important for advocacy to change policy, to change the law. Can we collaborate, we bring resources together, and we take it to the legislators and policymakers that can use it to change policies so that they benefit the people. Just wanted to share a bit of how we are trying to close that gap, and it has worked. Thank you.
Thank you. It's a wonderful example. And I think a reminder also that as scientists, those of us who spend a lot of our time in science and research, we have to make sure that the work that we're doing does not come across as elitist or top-down. We encourage our investigators to go into the field and to meet the people that they're working with and trying to find solutions for. And we have a bit of an epidemic of trust at least we do in the US and I think throughout the world, in terms of whether science is considered to be meaningful and useful or not. And anything we can do to try to tackle that is very important. Please. Oh, go ahead.
Hey, thanks. Sorry, I just wanted to also briefly respond to that point. So I think that's a really good point, that research funders have a really important role to play, and the way that grants are provided often results in this kind of division between the evidence and the implementation. So that's something that we were really conscious of when we were developing this program, which is a grant-funded program. that we're not just asking teams that already have the academic collaborators in place to apply for a typical research grant, that we're going out and proactively seeing where will this research have a lot of impact, that we're drawing on the expertise that we have within our organisation to be able to understand where the key evidence gaps are, where they can influence policy. We're working with other teams like Strategic Evidence. I have the head of the team here in the audience as well, with our policy team. So I think very similar to what you're describing, it's about having all of those stakeholders in the room and coming up with something between you, rather than saying, okay, apply for this grant, and then we think about that later. Thank you.
Hi, I'm Isha Kataria. I am a senior public health researcher with RTI International and currently a visiting scientist at IARC. I wanted to just share my experience of embedding implementation science in health systems. I co-lead an implementation science project in India which focuses on reducing the delay to diagnosis, which is a major problem in India. And one of the things that we have learned so far from our ongoing project is that if you have to embed it into the health system, you really need to get your right stakeholders in place. And I think we have been focusing a lot on stakeholder engagement, which just does not include people from the health system, but also from the community, people who will uptake your services, and also people with lived experiences. And I think that has been useful in helping us getting the buy-in for implementing or embedding, as you would say, evidence-based interventions into the health system, so that when we exit, it is the health system that can take it up. The other thing that we're trying to do is sort of as part of implementation research, we of course do contextualization and formative research, assessing what are the barriers and the facilitators. But one thing that we're trying to do is that for some cases, what we've realized is that you don't need bigger interventions. You have to see what is existing in the public health system, what is their capability, and with minor tweaks, you can improve the experience of the individual who's going to access the services throughout the cancer care continuum. And I think what we are trying to do is do those minor tweaks so that the public health system does not also feel that you're just letting too much burden on me to do all these things, and we have to get more people and things like that, because they will never work for us. So I think those are a couple of experiences while we are going through the project to share with everyone here. Thanks.
Thank you. Does anyone want to respond?
Yeah, no, thank you for sharing this experience. I grabbed from your first example the ownership, and I think here ownership of everyone involved in the project, but also the people or the audience that is going to receive it is very important, and also the people that you would like to implement it or to push it forward, right? Because we've seen this experience with the European Code Against Cancer and the Latin American one, and in these latest editions we've tried to involve all the stakeholders from the beginning with, for example, this formative research, trying to get what the citizens need, what the citizens want, how they would like to get the information, and also getting the leagues and several stakeholders to be part of it to be sure that they feel the product is theirs, right? So I think thinking of this ownership and taking into account that we need to make sure that everyone involved in the community with the project feels it's their own project, not only the scientists, is really, really important. So thank you for this example.
Please.
I am a journalist, and I have heard, of course, dozens of debates on the silly people who don't want anymore to listen to science and how to find the right recipe to make them swallow the pill. I am sorry to tell you that probably you are waging an uphill battle, because the reason the public is so reluctant to scientific message today has nothing to do with science and the scientific evidence. People want to throw tomatoes at science, they want to throw tomatoes at scientific institutions, they want to throw tomatoes at doctors. Why? This would be worth an analysis which I'm not going to deliver here. But sometimes it is supported even by the most prestigious and rigorous scientific institution. At the University of Geneva, Faculty of Medicine, no, shamanism is an official cause. And the trend towards so-called alternative medicine has been very popular and sometimes supported by a lot of doctors. You know, there are many reasons why now the public doesn't want science, even if it knows that science is true. First, we have been subject to a deluge of information, science information, health information, diet information for 2 centuries now. I cannot board the bus, I cannot go in the street and read posters, I cannot go to work, everyone, every day, everywhere, there is scientific and health pedagogy, I would say 2 or 3 hours per citizen. So people, like at school, they revenge against their teacher. Second, each family now on earth has a son or a daughter studying medicine. And the parents know that they study medicine to survive, they will have to brainwash a bit their patient and send them to 10 different doctors when one would be enough. So they know that medicine is very good for doctor, but less and less. It used to be very good for patient, but less and less so. Another example, and to me it is a real mystery. In Africa, a lot of people would eat a limb of an albinos claiming that it is good for health. But if their car breaks down, they will not go see the shaman. They will go to the mechanic. So there are surely reasons which have nothing to do with the validity of science and acceptance of science behind this growing trend of the public. But the public has tried to challenge the king. They have beheaded a few. It hasn't improved a lot. They have challenged church, then they have challenged their bosses and got better pay. Now they want to challenge the last power, which is truth. And they are much stronger than you are at that. They are much more numerous, and when they really need to act for health, they will do without informing you.
Thank you for your comments. Anybody want to respond? Okay, we are at time, yes. So we won't have a chance to respond, but I would like to say this has really been an invigorating session. Thank you for your comments. Thanks to everyone for your comments, and I'd like to thank the other panelists here again for their terrific presentations. And I think one thing we get out of all of this, including the comments we just heard, is that there's a lot to learn here, a lot of different factors to consider, and a lot of different disciplines that are relevant to the work that we're doing. So keep up the good work. Thanks for being in this mud pit with us, and thanks for coming today, and enjoy the rest of the conference.